evening, everyone. Thank you for joining. I'll just wait another minute or so before we make a start. Okay, just like to welcome everyone tonight to our second session in the Time of Dying webinar series. This evening, the discussion topic will be Anticipatory Prescribing in Palliative Care. And I'd like to start tonight by making an acknowledgement of country. I wish to acknowledge and pay my respects to the traditional custodians of this land. I pay my respects to their elders, past, present and future. I would also like to extend my respect and acknowledge any Aboriginal or Torres Strait Islander people that may be present here tonight. I'm your host for this evening. My name is Michelle Baxter. I'm a Regional Services Officer for Latrobe and Baw Baw. Hope you've all had a terrific Tuesday and enjoy the session that we have planned for you this evening. Just a little bit of housekeeping. So for your CPD activity points, these will be allocated once the evaluation survey has been completed, and we encourage you to also include your RACGP or ACRM membership details in order for us to allocate the points for this evening's webinar. Just some tips for this evening. If we could encourage you just to be on mute and video off, unless you want to share yourself on video. We love to see faces in the room, but this often drains on the internet within the webinar. We're basically running from 6:35 through until 7:15, where we'll also have a question and answer opportunity for the audience. We encourage you to please hold off with questions until the 7 to 15 time slot. We'll be recording this webinar, and we'll also be providing a copy of the documents via email post this webinar. Just wanted to share with you, Health Pathways is a really good digital health tool that the Gippsland Primary Health Network have. Basically, there's localised health pathways with a variety of different referral pathways for health professionals. Just wanted to highlight, obviously, the relevance of tonight. We have a localised health pathway for palliative care. So it also provides information around the voluntary assisted dying, COVID-19 and palliative care, and the terminal phase management, many other more options. If you haven't got access to health pathways, please reach out to Gippsland PHN and we'd be more than happy to organise for you to be connected. Your presenter this evening is Dr. Melanie Benson. She's a palliative care physician based in Gippsland Regional Palliative Care Consortium. So I will hand over to Melanie. Thank you.
Thanks, Michelle. I'll just share my screen and then we'll kick off if I can find it. Okay, here we go. Hello everyone, welcome back to those of you who came last week and welcome to those of you who are new this week. So as Michelle said, I'm a palliative care physician who has worked in the Gippsland region, and I've worked in most sectors in my career, so in the acute sector, community, public, private. I've worked with community services, palliative care services as well. I'd like to thank both the Primary Healthcare Network as well as the Gippsland Regional Palliative Care Consortium to ask me back to do these talks, and hopefully the techno gremlins stay away this week compared to last week. So this week we're going to talk a little bit about anticipatory prescribing in our Time of Dying series. So what I hope we'll cover in the next 40 minutes or so is understanding why anticipatory prescribing is so important. There's actually two roles for anticipatory prescribing, which I'll come to. Understanding the principles behind anticipatory prescribing, and I'm conscious though this is targeted at general practitioners, the principles work across community settings as well as residential aged care facilities as well as the acute sector as well. So I'll talk to that predominantly. How we prepare for some of the challenges that come up with anticipatory prescribing and how we can perhaps start to troubleshoot that, and that may tip into our question time as well. So as Michelle said, please feel free to leave some chat questions as we go along, but I will get to them at the end. So make sure you pop them in as we go along, because no such thing as a silly question. So as I had last week, a bit of a disclaimer that whilst these talks are around the time of dying, which is everybody's preconception as to what palliative care is all about, the last little bit of life, very much palliative care can be involved very early on in people's disease trajectory, particularly if they have troublesome symptoms or difficult psychosocial or existential issues. But very much the role of palliative care, which is done by both specialists such as myself, as well as people who are generalists, such as general practitioners, as well as geriatricians, as well as my nursing colleagues, as well as the social workers I work with, is that our focus very much is on affirming life and regarding death as not a failure of life or a failure of medicine, but part of the normal process of living. We don't intend to hasten or postpone death. Our focus is very much on relieving symptoms, helping people live as actively as possible right up to the dying time, but very much about support systems, both informal as far as carer support, but as well as working with each other to become a support system for each other in a team approach to deliver the care we need to as we approach the time of dying. What I didn't touch on last week was the sites of palliative care. Specialist pal care works in what I call a triangle of care when I'm talking to patients. So we talk about the community setting, so you can find palliative care clinicians, be they nurse specialists, medical specialists, in the community setting. You can find them in the acute hospital setting, particularly Metro Melbourne and the bigger regional centres. And then there are specialist palliative care units as well. And that's where the time of dying can occur. We'll predominantly focus on the first one today, which is home and residential aged care facilities of the home for the people that live there. So we know that from the Grattan report in 2014 that 70% of people want to die at home, but only 14% of people do. And there's a large number of reasons for why that doesn't happen. Some of it is what we talked about last week, is that we don't recognise the time of dying, or that we don't talk about the time of dying approaching. Some of it is carer confidence. So whilst the patient may want to die at home, if they don't have the carers that are able to support them during that time at home, they often require increased support if they can't get it at home. Sometimes it's around clinician confidence and knowledge around palliative care. And if you haven't had much experience with palliative care, it can be quite confronting on a personal and a professional level. A lot of it comes down to access. So if patients don't have access to a nursing support at home, if they don't have access to a general practitioner, at least with on phone support, if not home visits, that's a challenge. If people have got fragmented care, so they've got different care providers in different settings, so acute sector in Melbourne, a general practice that might be bulk billing, and then a community service, that can be really challenging to try and pull things together when the dying time happens. And access to specialist PAL care, it continues to be an issue, particularly outside the confines of Metro Melbourne. What we will be focusing on tonight, though, is around the other side of the slide, which is around medications, so access. So if patients don't have access to medications to be able to have their symptoms well managed at home, it becomes very difficult to be able to die at home. So access to medications, whether that's prescriptions, whether it's to the medicines that they actually need, so pharmacy access can be difficult. There's obviously challenging to get an evidence base in palliative care anyway because of the nature of our patient population, but certainly evidence around care of dying in the community continues to be an ongoing endeavour. There's a lot of misconceptions both in the general community as well as the medical community around the role of some medications in the dying time, which we'll touch on today, and concerns around when medications are to be used and when they could potentially be misused is a concern, and that comes up in Bauer's article, which will be provided in the care pack from the consortia at the end of this as well. I think the other side of it is people don't get to die at home because we don't talk about it and we don't plan for it. So whilst we don't have the scope to talk about advanced care planning, we can certainly flag, as we did last week, about not just at the time of dying, recognising that we need to plan for dying. We should be doing that beforehand in the weeks prior to the time of dying, and it doesn't need to be a formal advanced care plan, but it can be very much about preferences for where patients want to die, and that may be patients are pretty open. They might want to strongly prefer to be at home, they might be ambivalent, or some are very keen to stay at home for as long as possible, and we're seeing this more in COVID, stay at home for as long as possible where they can have family around them and then go into the hospital sector where perhaps there might be visiting restrictions. And then once we've elicited those preferences, we need to start planning. So I'll be leaning very heavily into the Safer Care Victoria anticipatory medicines guidance, and certainly this answers some of the concerns on the previous slide around lack of guidance, how to prescribe anticipatory prescribing medications safely. So this group, which I wasn't part of, came together, and it was a group of palliative care experts as well as nursing experts, both in an inpatient setting as well as the community setting, as well as consumers. And I think the important thing about this slide is, although we'll be talking a lot about prescribing and prescriptions, is that you'll notice that a lot of that, you can prescribe as many medications as you like, but unless you have support for the carers, they understand what they're doing in caring for someone who's dying, normalising that process, understanding the stress that caring for somebody that they love in the dying time places, as well as putting on them the responsibility of when to use medications, how to draw it, how to administer it, and some of their concerns about administering a dose very close to the time of death needs to be addressed and supported all the way through the time of dying. So carers and addressing the needs of carers is just as important as the act of prescribing. We'll touch on that a few times during the chat. So inherent in anticipatory prescribing is anticipation and prescribing. So let's just revisit anticipation. So as we've touched on already, what this really requires in anticipating getting to the dying time prior to diagnosing dying is acknowledging that the possibility of dying is becoming a probability. So there's lots of tools for that. Last week we talked about the SPICT tool, which talks about indicators that people are deteriorating, and that, as this slide shows, you know, it might be increasing hospital admissions. It's particularly deteriorating functional status, increased care needs, anorexia and cachexia is a large part of that. And then it's physical symptoms related to their condition. So with dementia, it might be difficulty with dressing, walking, increasing behaviours of concern. With heart and lung disease, it might be increasing dyspnea as well as increasing fatigue, for example. But certainly if those things are increasing, and as I said last week with the Karnofsky score, if their functional state is deteriorating to where they're spending more than 50% of their time in bed, that's when you need to start having discussions about preferences and about anticipating that death will become a probability in the coming weeks. But perhaps the most sensitive indicator, and whether that's somebody who is being discharged from hospital or whether that's someone who's not going to have any further active treatment or active chemotherapy, is asking yourself the question, would I be surprised if this person died in the next 3 months? Or would I be surprised if this person was going to die in the next 4 weeks? Or would I be surprised if this person was going to die in the next 2 weeks in particular? And if you're sending someone home to die, then very much that's the time to start thinking about and organising community services if they haven't already been in place. But the earlier you refer to a community nursing service and a community palliative care service means increased opportunities to make decisions with a team, and that can only be a good thing. The important conversations once you've recognised that somebody is deteriorating and approaching the time of dying is discussing goals and thresholds of care, which we talked about last week, and we'll talk a little bit more about next week. It's referral to community services, and perhaps demystifying that just a timely referral to palliative care keeps people out of hospital and helps us to plan for scenario A, B and C at what's going ahead. But very important is pulling out patients' preferred place of care and their preferred place of death, because that helps us plan with carers in particular. If there's some dissonance between what a patient wants and what a carer thinks they can provide, then if we pick that up early enough, we can discuss it and plan for many case scenarios rather than there being extreme levels of distress. Also understanding if people want to perhaps die in hospital and be cared for at home up until the time the dying time, then that will also guide your prescribing as well. So, anticipatory prescribing. Who do we prescribe for and when do we time that action? Now, in practicality, sometimes it's a referral to the community nursing service who will then approach the prescriber in the community when they notice that there is a functional decline. And that may come out of the blue for perhaps a general practitioner who hasn't seen their client all that often because the patient is spending a lot of time still attending specialist visits. So sometimes it can be a bit of a surprise if it's prompted from that angle. Sometimes it's when patients have been very poorly in hospital, and particularly in COVID times, they decide to go home for end of life care. But on the whole, there's two patient groups. First, there are those patients who might be earlier in their disease trajectory but might have difficult to control symptoms at home. And we want to make sure that there's good symptom management in place to prevent them from coming back to hospital unnecessarily. The second group are those who are anticipating dying at home and planning for that stage. So the first group, the emergency symptom support, it's not all patients that were referred to palliative care services. Perhaps 10, 15 years ago, there was an arbitrary rule that patients could only be referred to a community palliative care service if they had 6 months left to live. And all of those patients, and the community palliative care services heavily advocate for everybody to have anticipatory prescribing. But it wasn't very nuanced, and certainly and that was based on the oncological trajectory, which was quite predictable. Whereas we now know that, and we encourage patients who have diseases of any origin, whether it's malignant or non-malignant, to be referred in the final months of life, particularly if they've got difficult to control symptoms or anticipated difficult to control symptoms or carer support needs. We need to assess and reassess continuously during that process whether they need medications for difficult symptoms or whether we're planning for their terminal care. So if we're prescribing for emergency symptom support, that can happen at any time. It could be, that's included in people who are having nausea and vomiting related to perhaps their chemotherapy, that the medications that you might have for emesis at home, including subcut Maxilon, subcutaneous Maxilon, might be an emergency symptom support for someone who's having ongoing treatment from that point of view. Or it might be someone that you know that they've got a head and neck cancer, and you know at some point they're going to have trouble swallowing, and you need to have a contingency in place before you can switch them to syringe drivers or whatnot to keep their analgesia in place. So they might be on oral, say, MS Contin, and you know that they're going to have trouble swallowing at some point. You might want to have a subcut medication in place for them at some point. And then you've got the group that crosses over, so you might have something available for symptoms, whether it be pain or shortness of breath, but you know that they're going to tip into the terminal phase and may need the full suite of anticipatory prescribing for the terminal phase. For those patients who perhaps want to go into hospital for their time of dying, they don't need all the medications for the terminal phase. They need medications that they can have administered by a nurse or Ambulance Victoria or a family member while the ambulance is coming to take them into hospital. So there are a few concerns, some of which are raised by prescribers, some of which are raised by nursing staff, some of which are raised by family themselves, as you've got to make this decision for anticipatory prescribing medications with everybody concerned. So if consent is really important for the family for many reasons. One, it's a real trigger point that you've had the full conversation around planning, around death and dying, and some families will feel very hesitant about having parenteral opioids in the house, particularly if there's young family members, young kids or teenagers who perhaps could be at risk, family members who visit or who live there who have active intravenous drug use problems, in which having parenteral opioids in the house requires some strategizing around or planning. Or those patients who are at risk of diverting their opioids for financial or other gain because of lifestyle issues. So understanding all of those risks, it's a relative contraindication. It requires different strategies to be able to mitigate those risks and still meet the preferences of the patient as much as possible. But as I've already touched on, the care component is really important. So understanding that even if you're prescribing medications, that you've got family members who can conduct the terminal care, even if you've got the medications in play. And an example of this just happened this last weekend while I was on call for a specialist palliative care unit, where a general practitioner had identified that his patient was deteriorating. There's delays in the regions that I work because of COVID. There's sometimes a delay until specialist pal care nursing can get out to admit patients to the books. And the family were ambivalent and the patient were ambivalent about whether they wanted to come into hospital for the dying time. So the GP did a great job and provided them with this man had cardiac failure, with some oral morphine and sublingual benzodiazepine to manage his symptoms of agitation and dyspnea. But what transpired is without caring support, without professional nursing support, this family couldn't manage this gentleman at home. So with all the best will in the world and prescribing in the world, unless you offer as much as you can, sometimes patients need to come into hospital. And even with maximal support, sometimes the dying time can be hard and extra support is required 24/7. That's Plan C. So we've talked about anticipating the dying time and anticipating the prescribing needs ahead for patients. Let's talk about the prescribing. So luckily, as I've mentioned, there's some guidance available. It can be accessed two ways. You can go through the Gippsland Regional Palcare Consortium group, which has a bit of a cover sheet which just covers Gippsland specific considerations in anticipatory prescribing, which will also have a link to the statewide guidance. And I'd recommend at the end of today, everybody just getting online, downloading that or having a look at it just as a refresher, because it's a really good document, a very practical troubleshooting document to have a look at, clock it, put a shortcut on your phone, and then you know it's there for the future as well. So as we've mentioned, emergency symptom support is exactly as it sounds, supporting symptoms if they come up in an emergent situation until assistance and reassessment assessment can be sought. So for pain, it's often an opiate. For dyspnea, it can be an opiate or a benzodiazepine, and that's important in taking a history around dyspnea as to whether it's the subjective feeling of shortness of breath for the patient or whether there's a large overlay of anxiety. And many patients can articulate that they will become short of breath, then anxious, which will then make them more short of breath. So taking a good history will indicate whether you need one or both of those medications to manage dyspnea. Emesis, as I said, if somebody has a gastrointestinal malignancy, for example, or having treatments such as chemotherapy, which might precipitate nausea, then having an antiemetic that's either sublingual or parenteral, particularly if they're having real difficulties with nausea and anticipatory nausea prior to chemo, then that's an important strategy to think about. Then it's very important to think about the specific symptoms for the disease that we're talking about. So again, if it was dementia and behaviours of concern, then you might have behavioural strategies as well as pharmacological strategies for that. For those patients who are dying of perhaps a primary neurological condition and perhaps are already on anticonvulsants, one of the biggest discussions that I used to take phone calls about was a patient who would be on Keppra for epilepsy, whether it be in the setting of a primary brain cancer or not. And we could anticipate at the time of dying they're not going to be able to swallow their anticonvulsants. How do we manage that problem? And the answer to that question is clonazepam, and it can initially be sublingual drops, but then it can move on to subcutaneous twice daily injections as needed. The final 5 symptoms, so these we talked about last week when we came to the diagnosing dying time. Now we're just thinking about anticipating these symptoms being a feature of someone's dying time in our anticipatory prescribing. So the 5 symptoms are respiratory secretions, which have all of these: respiratory secretions, dyspnea, delirium and pain happen in about 50% of patients in the terminal phase. But there's a wide range in many of the studies. So for example, for delirium, most of the studies show that in the dying time, between 25 and 80% of patients have delirium. And as I think I mentioned last week, a subset of those will have an agitated delirium. So we know that these are the symptoms that in many constellations in differing severities may present themselves in the terminal phase: respiratory secretions, dyspnea, delirium, nausea, pain. So we need to account for those 5 when we're prescribing to allow people to die at home with their symptoms adequately managed. So what do we prescribe? Well, for pain, it's often an opiate. There's a reason there's 2 little stars next to the opiate. That's because we need to know a little bit about, if you've got an opiate naive patient, then you obviously dose accordingly. If you've got a patient on large doses of opioids, such as say a fentanyl patch, 100 micrograms per hour, or MS Contin 100 milligrams BD, then obviously 5 milligrams of subcut morphine is not going to be enough as an anticipatory medication. So knowing the opiate that they're on already is important, but also knowing if there are some metabolic or organ failure issues that will impact on how that patient will tolerate the medications is important. So, and of note, if people have renal failure with an eGFR of less than 30, then your safest opioid to prescribe in a parenteral form is usually hydromorphone or fentanyl, although fentanyl is very expensive and difficult to access in the community. So it's just important to recognise which opiate and what dose you use based on the patient's underlying condition. As I've mentioned, for dyspnea or tachypnea or cough even, we often use an opioid plus or minus a benzodiazepine in the terminal phase. For nausea and vomiting and dry retching, usually we'll use an antiemetic, usually either metoclopramide or haloperidol. The caveat to that is in Parkinsonian patients, because we don't want any of our medications in the terminal phase to actually create more difficult symptoms to manage. So again, if we use morphine in the person who has an eGFR of 6, then we're going to add to their nausea, we're going to add to their delirium, and we're going to add to their itch. So that's why it's important, even in the dying time, to treat each patient individually. We don't use Maxilon or haloperidol in patients with Parkinson's or Lewy body dementia because we may well make their Parkinsonian symptoms, particularly rigidity and the pain from muscle rigidity, worse for those patients, as well as the risk of extrapyramidal side effects. In those groups of patients, it's tricky to manage, and a conversation with your friendly neighbourhood palliative care specialist is helpful. But you can use ondansetron, but that's wafers, or you might need to seek a prescription for cyclizine, which is an antihistamine. which can be given subcut. For respiratory secretions, which as I mentioned last week is when people are dying and they retain their normal saliva, so it's not an overproduction of saliva, it's just that they have reduced coordination of their swallow and they have that death rattle, as it's called in the community. Often education is enough for families, but sometimes it can be quite pronounced and quite distressing. So as well as the nursing interventions, which is positioning, an anticholinergic is prescribed. In the acute sector, we often use glycopyrrolate. In the community sector, we often use buscopan, butyl bromide, hyacinth butyl bromide. For delirium or for a non-agitated delirium, often we don't need to manage it pharmacologically at all. But for agitated delirium, you can use a combination of either a benzodiazepine or an antipsychotic and benzodiazepine. So the caveat with delirium in particular is that there's a small subset of patients that will get a paradoxical agitation with benzodiazepine, be that sublingual clonazepam or lorazepam or subcut midazolam. And certainly we need to be mindful of that if people's agitation are getting worse. If we just increase their dose of midazolam, we're actually making the symptom worse ourselves. So in those group of patients, we tend to use a combination of haloperidol and benzodiazepine. So when we're prescribing, again, as I've mentioned, previous medication history is important, as well as their comorbidities. We need to think about which route we're going to use. So maybe for emergency symptom orders, we may use buccal or transmucosal or even sublingual medications, or we might use parenteral. Very rarely do we use intravenous access in a palliative care setting. So when I say parenteral, I usually mean subcutaneous. And some of that decision will also come down to the administrator. So if you're relying on family members to administer medications, you need to be aware of who's going to be happy to be trained to administer subcutaneous medications compared to those who might draw the line at injectables and will only use sublingual medications or oral medications, at which point you might need to rely on visiting nurses, in which case there's going to be a delay. Or I know in some of the metro areas and some of the regional areas, Ambulance Victoria, if they've got the medication and the orders available and clear goals of care and plans, will come and give patients breakthroughs as well, or anticipatory medications. You need to prescribe enough medication, keeping in mind that patients may use multiple doses for at least 72 hours. So enough to get from Friday midday to Monday midday without public holidays like the upcoming one. Christmas is even worse. So you need to make sure that even with multiple doses, that the nursing staff will have enough, or family will have enough available to get through to the next business working day. So that over Christmas and Easter is usually the worst, and patients run out of medication because they've only had 5 ampules given to them and they need to last 5 days, in which case you've got 2 scenarios. 1, that patient ends up in the emergency department on Christmas Day, or 2, you've got an after hours nurse trying to find a prescriber on a public holiday, which is stressful for everybody concerned. And often the prescriber is somebody who doesn't know the patient. So really consider the medications you're prescribing, why you're prescribing them, which route, the amount you need to prescribe, and also the contingencies that you might need to put. If that patient wants to die at home, you might also need to factor in the amount that may need to go into a syringe driver over the weekend. So this is an example of an algorithm just to walk you through some of the doses. This algorithm is a Gippsland algorithm designed for inpatient care, but the principles are the same. It's also an addendum to the Safer Care Victoria guidance. So it really just walks through what we've talked a little bit about. So again, if a patient is anticipated to have pain in the terminal phase, then you can think through the processes of were they on an opioid before? What was that dose? Or have they been on other opioids? Like methadone's often a tricky one, in which case you want to speak to a specialist palcare, CNC, nurse practitioner or physician as needs be. Or if the opiate naive, you might start with morphine, as we talked about over here. So that's symptom number 1. Here are the 2, 3, 4, 5. So nausea and vomiting, start with Maxilon, but we might move through haloperidol, or when cyclozine's fallen off the bottom here, but cyclozine, midazolam, and sometimes we might use the haloperidol if we need it. Dyspnea, opioids, respiratory tract secretions, so hyoscine butyl bromide or buscopan or glycopyrrolate. We very rarely use atropine anymore. It's very old school, and so it stays on charts, but it's because it causes profound bradycardia and profound dryness of mouth, symptomatic for patients who might be semi-conscious. And when we've got other options, then we tend to use one of these two and save atropine for if we can't access anything else, or if it's very refractory to the other anticholinergics. So site of care is important. And as I've said, the principles for prescribing that we've just talked about can fit into any of those settings, but there are some certain logistics that are specific to the community, but there are for each of these settings. From here on in, we're largely talking about prescribing for home, but that's important for those of you who work in the hospital setting, whether it be emergency or even the wards, to think about, well, if this patient's going home to die and may not be able to get an appointment with their GP, telehealth or otherwise, or they might not be able to link in with services for some time, you might have to organise the prescribing of anticipatory medications and train the family before they go home while you're waiting for the nursing services to pick them up at the other end. So there are certainly crossovers. And so whilst the sites of care for dying might be home, residential aged care facility, or an acute hospital, there's a lot in between these sectors, and communication is important and planning is important across these sectors as well. So let's talk about the logistics of how we prescribe. So often there's two ways that a prescription will be asked for. One is, as I said, the community services have flagged that this patient is deteriorating and they want to die at home, but we don't have any emergency medications. And you as a general practitioner might be asked to prescribe, or you've referred to the community nursing service and they have said, that person's GP is away, can you please prescribe the anticipatory medications for them? So a script needs to be written, again, as I said before, with enough to last until the next medical review. Then there also needs to be an order written for the nursing staff or the AMBOs who need to administer the medication. So often GPs will be asked to do both a script and an order. You need to think about where those medications will be stored. Community nursing services will often help family members with this. And sometimes they'll even say draw up 3 doses of a medication when a patient's in the dying time for the family to administer. But in those families with perhaps concerns around people with diversion risk or just age-related risks, teenagers, 20-year-olds who might be at risk, or those that are not so sure, we need to think about locked boxes is really important. So how the medications are going to be stored, as we've talked about, who's going to administer the medication. And then the important thing is planning for ongoing communication and review. So it's one thing to write scripts and orders, it's another to know when they're going to be used and when you're going to be contacted about, because once you write a script, you're responsible for it. So you need to be confident that it's going to be used safely, but also that you're involved in the process if that patient's symptoms continue to be an issue. It's not a set and forget process. So some of the challenges we touched on at the start was around access, so to prescribers, to medicines, to care. So some of the access issues are very much around, if you take on a client, then you need to be willing to hand over those patients. And when you hand over a patient, when you go on holidays, you let your colleagues know that they might have anticipatory medications in place, or that they might be, you wouldn't be surprised if that patient deteriorated in the next 2 months and they'd be appropriate for anticipatory medications if the time came. Access to medicines. So again, there's some patients who, again, like hydromorphone, as I touched on before, or cyclizine, there might be some medications that need to be organised through either a pharmacist. Particularly my experience working in Gippsland is hydromorphone, cyclizine, anything beyond your regular, even sometimes midazolam, can be challenging to get in some of the smaller community pharmacies. So sometimes you have to plan ahead and you need to order it in. You can't wait for it to be ordered on the day before or the day it is due. And some of the even more specialised medications that we might use, and we'll touch on some of them next week when we're talking about palliative sedation, some of those, and even cyclizine, sometimes need to come from a pharmacy at a tertiary hospital or a sub-regional hospital, like for Gippsland from Traralgon. So you need to plan for where these medications come from. I think it's always really important for many of the community nursing services to know where there's a 24/7 pharmacy, and most of them do, but to know where there's a 24/7 pharmacy where you can organise these medications from, whether the problem crops up on a Friday night before a long weekend, for example. So to be able to get scripts filled is really important. And access to care, as I said, particularly COVID's highlighted this even more, that if you're thinking about referring to community PAL care services, community services / PAL care services, then do it sooner rather than later, because the closer you get to the city, the longer the delay till people get put on the book sometimes. So I think, getting involved, and again, as I mentioned last week, if you leave a referral to the very last minute, then there's no chance of rapport. There's no chance of people to understand, referrals in the community, whether it be the nursing colleagues, whether it be nurse practitioners who visit, whether it be physicians like myself who visit. If we don't get a chance to get a feel for a patient's trajectory ourselves, it makes it hard for us to support the family and build a rapport, but also to advocate for them and to help support you in your decision making as well. I think it's really important for everybody to communicate. As I said, discharge summaries are important. If you're discharging someone who will possibly die in the next week or two, picking up the phone, speaking to that patient's general practitioner is really important. If it's not anticipatory prescribing medications that's the issue, it's doing a death certificate. Those are the two things that causes a lot of strife unless the communication happens. I think communication between care disciplines is really important, between specialists and general practitioners and community specialists, between medical staff and nursing staff, all of which is really important. We all need to pull together when someone's dying, but if we don't talk, then assessments and communication can be the downfall of how a patient can stay at home. And of course, speaking to the family is really important. So some of those strategies are anticipation. So again, being mindful of where your patient is in their trajectory. Communication, seeking collaborative histories from specialists in town, from the nursing staff, and vice versa is really important. Coordinating, so all the community nursing services with a PAL care bent usually have a multidisciplinary team meeting, and that's a really good opportunity to ring into, touch base with, to then get the feel for the issues in a certain family and how things are going when medications are starting to be used. Risk mitigation I've touched on, so that's a little bit like locked boxes. Sometimes it requires strategies about with your local pharmacy about controlled dispensing of medication. In COVID times where we weren't sure whether patients, could be seen and whether we could get into pharmacies and that sort of thing, a lot of the community services advocated for the scripts and the orders for medications, but they sat in the pharmacy until they needed to be dispensed. So that's in that way, we're not prescribing and adding to the overlay of medications that don't get used in the community. We've stratified that risk. So thinking innovatively around that is really helpful. And oversight and review is really important. So what I do in the hospital setting, when people are a bit angsty about whether we should write up opioid doses now or not, I just say, well, write it up so the nurse has got it at 2 o'clock in the morning, or haloperidol if delirium is going to escalate itself, and when the patient sundowns from 2 o'clock in the afternoon until 2 in the morning, unless you have a medication there available to you, you've got two options. One, the patient suffers till the morning, 2, you get called at 2 in the morning for an order. Or 3, you can have the medication available and they can contact you when they're using it. So then you know when the medication is being prescribed and whether it's being used appropriately. And this document is really great, actually. It was in the back of the guidance, and this is a plan for family members. So telling them when they should use medications. But it can be in a residential aged care facility really helpful to have that written down for the nursing staff as well. So, you know, we use the morphine, and that's to be used for dyspnea and pain. The haloperidol is to be used for nausea and agitation. The glycopyrrolate is there for respiratory secretion. So giving clear directions is really helpful. Writing in the medical notes, if this patient's needed more than 3 breakthroughs or 3 doses of your medication, you need to pick up the phone and speak to someone, because we probably need to put this person on a syringe driver. So it's not set and forget, or otherwise you have nursing staff who might administer medications and keep administering medications over a weekend, in which case a patient maybe should have been seen instead of just going on with the breakthroughs as well. And so these are real prompts for assessment, and they might be just phone conversations and phone assessments, or they might require a visit at home by a nursing staff member or by a medical person, or they may well require a trip to the emergency department. So the first use of medication, as I said, just gives you an indication that things are changing. And that might be just the family pick up the phone and let the nurses know, and perhaps someone can see that patient in the next 24 hours. If there is a new or a rapid worsening in symptoms, a pretty prompt review needs to happen. And an example of that might be somebody who's maybe been deteriorating, but very suddenly get very agitated, a lot of pain, particularly abdominal pain. What's often missed in the terminal phase, or the tipping to the terminal phase, is urinary retention because of constipation, because of perhaps some of the other medications, opioids in particular. And instead of managing that pharmacologically, a good old-fashioned catheter can help a lot. So a clinical review for retention can be really helpful. Or if somebody was going along quite well and had a Karnofsky of 70, so that's up and walking around, and they suddenly deteriorate to a Karnofsky of 30 with dyspnea, you have to wonder, well, maybe PEs, maybe we need to exclude PEs. This might not be the dying time. There's something reversible or manageable here. So an unexpected deterioration. Distressing symptoms need ongoing review, because they might be that if these days we don't need to get to hundreds of milligrams of morphine and midazolam. If you're using that higher doses, you're not managing that adequately, and we've got other options, and we need to review the medications. You might actually be contributing with big doses of morphine. You might be contributing to their pain through hyperalgesia. Big doses of a benzodiazepine, maybe you're contributing to the agitation. So really distressing symptoms require a review, and perhaps a discussion with your specialist palliative care nursing consultant, nurse practitioner, or palliative care physician. Distress carers always need review and support. Refractory symptoms, we've just talked about, and escalating medication use, and the adverse effects from medications we talked about. So there's plenty of reasons to reach out for help, and there's often help, if not in person, at the other end of the phone. Drug conversions, if you've got to convert someone from MS-Contin to subcut hydromorphone, and you don't feel confident with that conversion, or you've looked up an app and you just want to bounce it off someone, you ring. If you are worried about, is this the time to prescribe or not, you ring. If you're concerned about how your staff in the residential aged care facility are going to manage these terminal care symptoms, then you ring your local specialist palliative care nursing service, and they can often provide support and education within the residential aged care facility. Speak to your local pharmacist or the pharmacy at the local hospital or your local palliative care service around getting some access to medications if your first line terminal care medications aren't working. So if you need help, set up a signal. There's usually someone who can find. You start with your local service, you move to your local regional hospital, which will often have advice, if not a service. And all the tertiary hospitals will have a 24/7 palliative care physician on call who would almost always be happy to answer questions or redirect you for where to get them. Lots of references, which Annie from the consortia will send copies of. Go through any of those websites, the consortia, Palliative Care Victoria, or the DHHS advice line around finding palliative care services if you're not sure. The LDAC guidelines are great for prescribing and managing the dying time in those, particularly in residential aged care, the guidances I've talked about. And thank you again to everybody from the consortia as well as Primary Healthcare Network for supporting these talks and talking around these tricky subjects. So if I can get off my slides, I'm happy to answer any questions people might have. Let's see how we go.
Thanks, Melanie. You did a great job.
Thank you. I'm a little bit over, but that's always the way.
That's okay. That's fine. So we've just had the one question come through so far from Grace. People with advanced dementia, are there specific behaviours that could indicate terminal stage, i.e. severe agitation?
I think certainly that's a body of work that myself and a couple of geriatricians that I'm working with are working on. I think advanced dementia is probably one of the last frontiers for specialist palliative care to address, but certainly refractory. We've had a cluster of patients that we've been looking at cases around, and certainly escalating behaviours is a symptom of, without a reversible cause, can be one of the really troubling symptoms at the end of life in particular. And people who have had agitated behaviours of concern can continue to have agitated behaviours of concern into the terminal phase. And certainly I've seen a few patients, and that it's really difficult because it's challenging to assess the rest of their symptoms. So their behaviours can get worse if they've got unaddressed symptoms like urinary retention or pain. So there's pain scales for people who have got dementia as well, and a non-verbal even, called the Abbey pain scale. So that's really important to monitor. And again, it's one of those conversations that you have with the family, is that this is a symptom of their disease that may escalate towards the end of life. And just like if it was pain in cancer, we'll try everything to find reversible mitigating management for it. So if it was cancer pain, you'd manage them with an opiate and have discussions about managing the side effects of constipation and drowsiness. For behaviours, it's often things like quetiapine or risperidone, but sometimes their behaviours will become problematic despite that, and we have to have the conversation, which will move into next week's conversation, about whether we need to err on the side of sedation to manage those symptoms. The difficulty with dementia, as I touched on last week, is that people may have a very long period of time with challenging symptoms and functionally being quite functionally poor and bedbound, or not eating much, or being quite fragile in a bed, out of bed, wandering, but that will deteriorate towards the end of time. So it is really difficult, and that's where a multidisciplinary team is really important. So speaking to the nursing staff who know them every day, if they're in a residential aged care facility, speaking to their family members and getting them to take a step back and work through how were they compared to a week ago, a month ago, and that, or a day, 7 days ago. That will give you the best picture you can in working out whether their agitation is a tipping from dementia agitation into agitation of dying. But again, if they've been very agitated as part of their illness, it will more likely than not escalate towards the dying time as well.
Thank you. I've got another question that's come through from Deborah. You don't mention levomeprazole.
No, I don't.
Did I pronounce that right? Is there a reason you don't recommend it for delirium and nausea?
Because it's predominantly because this is a community presentation. We do use levomeprazole, but primarily under the guidance of specialist palliative care clinicians. For those who don't know, it's a very old antipsychotic drug. It's a very dirty drug, but it's very helpful. And again, I'll mention it more next week. We use it for people with refractory nausea and vomiting. So we will have moved through most of the other antiemetics. So you wouldn't put it out there as something that you would use for anticipatory medications, but you might have it as a plan if they've moved through, if they've got refractory symptoms down the track. So levo is used for a third line for nausea, and we use it for palliative sedation. So people who need to be intentionally sedated towards the end of life. But it's usually under they've often had very difficult to control symptoms to that point, and they will have been involved with a specialist pal care service, hopefully, to guide through that. And it's accessing that medication, particularly outside acute hospitals, which is the real challenge.
Thank you. I haven't got any other questions that have come through. If anyone has any questions, they don't feel comfortable typing or would just like to unmute themselves, I'm sure that's an option that
you're in a safe space.
We can support, yeah.
Just going to check the chat box here. Do we answer those ones?
Oh, hang on, there's something in the Q&A.
Yes, there's a couple of questions here.
In the Q&A, yeah. Are you happy to talk to those?
I can do. I haven't made an opinion on medicinal cannabis because two reasons. One, we don't usually use them as an anticipatory medication towards the dying time. Certainly it might be used by some practitioners for symptom management rather than emergency symptom support. The other reason we don't usually offer it as a first line in specialist palliative care is that we're still waiting for the evidence for it. So that's why it hasn't, there's certainly not expert evidence regarding it in the palliative care sector, let alone in the literature at this stage. So whilst we don't discourage patients from using it, we don't use it as a first line and offer it in guidance at this point. What do you think the most underrated medication in palliative care is for managing agitation? Oh, that's a big question. Underrated medication. Look, to be honest, when I work in the community, I often only prescribe 4 medications. I often prescribe an opiate. I often prescribe haloperidol. I often use both for nausea and agitation, and I think it's underestimated. Certainly if you're using it, the evidence is in delirium outside the terminal care setting. It can make patients more sedated and impact on their quality of life in the terminal phase. The combination of a benzodiazepine and haloperidol can usually manage most agitation quite well, but levomethormazine is certainly our backup medication that we use more than anything else. Can you explain hyperanagesia briefly? No, I can't explain it briefly, but I can explain it with a couple of bullet points. Look, opioid-induced hyperalgesia is a central process, and it comes down related to we get pain nociception from our peripheries, and then we travel through our peripheral nerves through the dorsal column, where we have receptors, both opioid and NMDA receptors. And the NMDA receptor potentiates pain signals to the central pain services. And what happens with hyperalgesia is patients often down titrate their opioid receptors, but they might get upregulation of NMDA receptors, which then potentiate pain. And often continuing to give opioids in that setting can set up pain cycles. That's why a lot of chronic pain or persistent pain specialists will often deprescribe opioids for patients with persistent pain. How it presents in the terminal setting is often patients have widespread allodynia, which means the patients can't even be touched in places where they never had pain before. So they'll often have the nurses can't touch them or move them without them having exquisite pain. In those patients that are not in the terminal phase, we might think about using medications that block the NMDA receptors, and that's ketamine. Or methadone, which has both opioid and NMDA receptor activity as well. In the dying time, it is more tricky, and sometimes we use ketamine in specialist palliative care settings. Sometimes we have to have discussions like we will next week around if we can't manage patients' pain with many other modalities, we might have to think about making patients sleepier for them to be more comfortable. More than anything else. which is a nice segue to next week. Any other questions? No such thing as a silly or scary question.
No, everyone's very quiet tonight. Okay, well, we might leave it at that. Thank you so much, Melanie, for your presentation tonight. As you've mentioned a few times, we will actually be meeting again or providing another webinar next Tuesday evening, which is the 27th of October, on management decisions and plans, including palliative sedation. So yeah, I'd just like to thank you all for attending this evening and taking time out of your busy week. You will receive a survey, a certificate of attendance and a registration link for next week's webinar if you haven't already registered. And yeah, from Gippsland PHN, I'd like to say thank you very much.
No problem. Thank you, everybody. Have a good evening.
Thank you.
Yeah, bye.